Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jennifer Blanchette. Today's episode is part 5 of a 12-part series entitled COVID-19 Answering the Questions. This series features brief updates on the latest incidents and clinical data related to COVID-19 diagnosis, prevention, and management, each followed by an in-depth question and answer session that's designed to address infectious disease specialists' most pressing COVID-19 questions. During today's episode, Professor David Heymann from London, United Kingdom, will provide an update on the epidemiology of SARS-CoV-2 and evidence-based interventions for reducing transmission. For more information about Professor Heymann and for a link to additional online education from CCO's COVID-19 Comprehensive Resource Center, please visit the show notes for this episode. Now let's get started and hear what Professor Heymann has to say about this important topic.
Thanks very much, Jennifer. Are you hearing me all right?
Yes, you sound clear.
Okay, great. Okay, well, I'm going to go to the first slide here. And this first slide is just what comes from I think I'm on the right slide. Is that correct? Yes. This slide shows you what's the Johns Hopkins University is reporting. What's important to remember on this is confirmed cases are really not all the infections. They're only what's reported as positive by the country based on what its strategy is. So, for example, in the UK at one point, they were only testing people who were admitted to hospital. So their confirmed cases were only cases admitted to hospital. China was reporting all infections as cases at one point in time. So they had many, many more cases than just those that were going to hospitals. So what you see there, the confirmed cases, are really confirmed infections based on various testing strategies throughout the world. And they can't really be compared in any way and give a good idea of what's going on. And remember, this is a number of a total of 14 billion in a country, in a world rather, where there are 7.5 to 7.7 billion people. So you can see it's quite a small number. The deaths equally, but the deaths are more reliable because they do tell actually what's happening in people who are admitted to hospitals and those who die. So this is a good reflection. It's a much more constant reflection, and it's a much better way of judging what's going on in countries to look at the mortality rates. And finally, those that recover are those that are reported as recovered by various countries. So though this information is useful, especially the number of deaths, it's really not information that should be used to compare country to country. This is that same information put on a graph on a daily basis, and what you can see is that the pandemic is increasing in all countries, and this is done by different regions. These are the World Health Organization regions, and what you can see here is that Africa, the blue, is of course the place where there are the lowest number of cases being reported each day. There are some hypotheses as to why that's occurring. It's possible that it's just earlier in the introduction of cases, mainly from Europe into Africa, that are now amplifying in transmission, or it could be due to other things such as the median age of people in sub-Saharan Africa, which is 19 years, or it could be due to the fact that the elderly who are more severely ill are in small villages where the outbreak has not yet arrived, and those people who are becoming infected are not really becoming sick or noticeably sick. So there are many reasons as to why this might be occurring, and it's just now to wait and see what's happening. Moving on to the next slide, you can see here the total deaths by region and date, and this is the same thing again. The deaths remain low in Africa, whereas they're high in many parts of the world. And to the surprise of many countries in the world, the US has quite a high mortality rate, as you'll understand, comparing it with what's going on in other countries in the world. This is very important for the US because it does in many ways affect the image of the US. In fact, I'm mentoring a woman who's an epidemiologist in Mongolia. And when I spoke with her the other week, she said, who do I turn to now for guidance? She says, North America and Europe haven't done as good a job as Asia. Am I supposed to be looking towards Asia? And I think it's just a reminder that we need to do better in what we're doing in the United States, better understanding between the political leaders and the public health leaders as to what really needs to be done. And this occurs both in states and at the federal government level. Moving on, I'd just like to say a little bit about the epidemiology and intervention. And before I start, I'd like to say that despite these tremendous geopolitical difficulties that are occurring in the world, technical people from around the world are sharing information through the World Health Organization and also in peer-reviewed articles that the journals are reviewing very rapidly and placing in front of their paywalls. So there's a lot of understanding that's come despite these geopolitical tensions in the world. And that's let us understand very rapidly a lot about this virus, but there still remain some gaps. We know, for example, how it's spread. It's spread by droplets, either made when you're speaking, singing, coughing, or sneezing. And those droplets can either transmit directly face to face or in an aerosol. And WHO says that this aerosol, from the evidence that they've collected, is about 1 meter. Over 1 meter, people should be safe, and that's why WHO recommends physical distancing of at least 1 meter. But there is concern that this might be, in some situations, able to travel more than 1 meter, therefore being airborne. And that could be through currents in the air that take it further, a whole series of things. Remembering, though, that that droplet must remain moist in order that the virus remains infected. The groups at risk, we know that healthcare workers are at great risk, and we know that individuals with comorbidities and elderly are at very great risk of serious illness and of death. Transmission patterns, we know that it transmits symptomatically, and it transmits from the time of the onset of symptoms to about 7 days or even more afterwards. You'll know better from your clinical experience looking at patients. We do know that there's also pre-symptomatic transmission, and from studies in Singapore, we understand that about 6% of infections could be occurring from people who are 1 or 2 days before the onset of signs and symptoms, very much like other viral infections that are transmitted respiratorily, such as measles. It transmits differently than influenza. This took a long time for people to understand, especially for the epidemiological modelers. We know that this disease causes discrete outbreaks that can be contained. And if you think back to South Korea when they had their major outbreaks linked to religious gatherings and church ceremonies, we saw actually that they could contain these outbreaks by good contact tracing, whereas you could never contain an outbreak of influenza by that same methodology. So though transmission, the reproductive number is thought to be greater, transmission is different than it is for influenza, and still, this virus causes discrete outbreaks that can be contained. There's, of course, a need for rapid diagnosis, and we're at a limitation because of the absence of any antigen diagnostic tests that have been validated other than real-time PCRs. And so we're at a disadvantage, although there are some diagnostic tests in different formats looking at the antigen, which are being developed and hopefully will soon be validated as being highly sensitive and specific. If they're highly specific and not highly sensitive, then they could serve as a triage. Those that are negative could be then screened for PCR. Use of masks, we know that masks protect others, and that's why they should be worn. When people can't physically distance from others, they should be wearing a mask. That includes in public transport, that includes in areas where in elderly care homes where there isn't a need for PPE, but there is a need to protect those people who are being dealt with and for which there isn't physical distancing possible. We know that masks don't protect against infection, so they're not a self-protection means. Physical distancing and hand washing remain the caveat. Importance of physical distancing, we know that 1 meter, greater than 1 meter, and hand washing. So these are the strategies that WHO is promoting. And the world really got off to a very difficult start in this outbreak because what happened was China locked down immediately, thinking that possibly, and rightfully so, that they could perhaps put this back in the box, this virus, and they could stop the outbreaks from spreading. So they stopped international travel as well. What they didn't understand at the start was that this virus doesn't transmit the same as SARS coronavirus. SARS coronavirus, as you know, reproduces low in the respiratory system. It takes a deep cough to get it out, or a procedure of pulmonary lavage, whereas the current coronavirus reproduces in the upper respiratory tract, and it's more easily transmitted to others. But what happened in Europe was that Italy all of a sudden had an overwhelming situation of people in their hospitals, and other countries became very concerned, and the modelers suggested that in order to suppress the virus transmission which was occurring and protect the hospitals, there needed to be some scenarios provided to the policymakers. And those policymakers convinced in North America and in other parts of the world that they should emulate what China had done and lock down in order to suppress virus transmission, while not regarding what was going on in other countries in Asia, where they were using outbreak containment activities and intermittent lockdown to obtain the same result that China had obtained by its lockdown. And we can talk about that more in the question and answer session, if that's useful. Moving on, we now have countries that are coming out of their lockdown, or countries that have not really gone into those lockdowns, and they're faced with what do we do to make sure that we can get this outbreak under control without vaccines and without therapeutics, because they're just not available. So there are three things that we can do, and that don't take anything more than good epidemiological skills within a country, good patient management, and diagnostic testing. So we need to shield the risk populations. We need to prevent infection among populations with risk of serious illness. That includes elderly persons and those with comorbidities, including obesity. And we need at the same time to make sure that healthcare workers, healthcare professionals have the PPE that they need to prevent infection. We need to contain the spread, and there are two ways we do this. Rapidly detect cases, test them, get the results rapidly, and get those patients isolated and managed by the clinicians. And at the same time, we should never stop. We should continue with contact tracing, identifying all contacts, having them either self-isolate or quarantine in some way for 14 days in order to interrupt chains of transmission that will take the virus further into the community. And the third, we need to understand the epidemiology so that we can intermittently lock down, as countries have done. In fact, as you know, South Korea, Hong Kong closed down their nightclub parts of the cities when they understood the transmission was occurring among students in those areas. Certain schools remained open, but they closed down when they saw transmission increasing. Then they unlocked them again when they saw that transmission was not occurring because they had monitoring systems in place. And finally, populations have to contribute to this in understanding how to protect themselves and protect others. Protecting themselves through physical distancing, through hand washing, protecting others by wearing a mask when they're in a situation where they can't physically distance. And they need to learn how to do their own risk assessments in order to do that most appropriately. So what will we see as we continue? Well, hopefully we'll see that virus is suppressed in all countries, that black peak decreases to a gray peak, and then that suppression measures can be intermittently done when necessary based on the epidemiology while continuing to decrease transmission into the communities by good systems to identify those who are sick and identify the contacts and make sure those contacts are self-contained. We're getting lots of information from many, many different sources. And this is an article that's just recently been put online that's showing the transmission patterns in households and in non-households in South Korea. And what you'll see is a surprise, and again, this is initial information, but the surprise is that there are populations which were not suspected of being at greatest risk, which are appearing to be at greatest risk of infection, and that includes people 10 to 19 years of age living in households. That doesn't then hold true as you go back into the community in the non-household situations. So I will turn it back to Jennifer now. Thanks for your attention. And I'm very happy to answer any questions that you have, either about the presentation or otherwise. Thanks very much, and over to you, Jen.
So with that, we will move on to the question and answer session, and we've had quite a lot of questions, so we'll get started with the first one now. So Professor Heymann, Craig asks, what do you recommend as a case definition for the percent positivity? The precise case definition is important, for example, when using a percent positivity for comparing across states and when making decisions regarding quarantining people arriving from a state with a particular percent positivity.
Well, there are two definitions that can be used, and I think probably either one of these is effective in looking at what's going on in states, which I think was the question. One of those is, and it won't tell you necessarily the number of infections in states, because it's very difficult to do that based on differing strategies in different states. And so, a good gold standard is the case fatality ratio, which is the number of cases, for example, admitted to hospital with signs and symptoms of COVID, positive test, and the number of deaths among those who are tested positive. So that could be the case fatality ratio, and there could be an infection fatality ratio if indeed it were known that all people were identified due to a testing strategy. But it's hard to test people because so many people have either very mild symptoms or they think they have no symptoms at all. And therefore, you can never get a good grasp on the total infection rates using a test for a virus detection. But there are serological tests that are available. And those serological tests, the only one that's really valid at present that people count on is the neutralizing antibody studies, which are looking at the antibody in a laboratory to see if it neutralizes the virus and if it prevents it from reproducing in the laboratory. Those tests are costly and they're timely to consume. And there are some rapid tests. Some of them have a lower sensitivity than you would expect, but I believe they'll become more and more important in the time. And therefore, you could be looking at the antibody prevalence in states in random samples of different population groups, which might give you a better idea of what's going on in states if you're looking to compare states.
Okay, that's a good point. Okay, the next question is from Girish, who notes that the WHO concedes that it is not just aerosols transmitting. What is your opinion on that?
I don't think WHO has conceded that it's not aerosol because aerosol means either close 1 meter or further than 1 meter. What they have said is that they are looking at the evidence now to see whether it does go further in an aerosol than 1 meter. And if it does, then that would be what would be called airborne transmission. So at present, WHO is not conceding or not, all they're doing is looking at the evidence. And there are a couple studies, one study in particular in China, which suggests that people who were sitting close to an air conditioning unit in a restaurant might have been infected from a virus that was transferred through that air conditioning unit because others in that restaurant didn't seem to be infected. But it's really a difficult question to answer whether or not this is transmitting. And one of the best ways to do that, and some of the ways that it is being done, is to put an animal, a test animal, in a cage in certain areas, such as hospital rooms or others, where it's suspected that there might be transmission. And if so, then that transmission would be picked up by those animals who would then be carrying the virus. So there are studies that are underway to determine this. But WHO really is looking at the evidence. And I just want to correct a misunderstanding. Airborne transmission is from aerosols. Aerosols are droplets suspended in the air. They're going 1 meter. We know they can transmit and cause infections, such as they did at a choir practice in Seattle. But we don't know whether they can go further and be picked up by air conditioning units and transferred to others. We do know from one experience that airlines, in airplanes, people sitting in front of and in back of people with the infection appear to be the only ones at risk on airplanes. But that's all to be confirmed as time goes on. These are only just basic information which is coming into WHO. So for now, two ways of transmission: direct face-to-face droplets, aerosol. Aerosols, in certain instances, when an air current picks them up, can go further than 1 meter, and that would be called airborne transmission.
Great, that was really helpful. Thank you. Okay, we have a question from Rosie. Are children less likely to transmit the infection? Is it to each other or to adults as well? And what is the cutoff age?
Some of the evidence from Singapore suggests that children don't transmit as easily as do others. But there's really no answer to that question. We know that children can get infected. We know that children can become very sick, but we just don't have the answer yet of what kind of a risk they pose. But for people who live in households with young children and with elderly, especially elderly who might have comorbidities, it's very important to keep those elderly shielded from all people who might be carrying infection, including children. We do know, though, or we do believe anyway, based on the evidence that is available, that this isn't a disease like influenza, which is transmitted among children in daycare centers and schools and then goes home and transmits in the household. It doesn't appear that this is occurring in the same way. There may be reasons for that. Think of the population with influenza, think of the population with COVID. With influenza, almost everybody who's older has some type of immunity, and the most susceptible would be the younger children who don't have immunity because they've never been exposed to the infection before. Whereas in COVID, we're all at the same risk because none of us have really been exposed to this before, we believe, unless, of course, antibody from other coronavirus infections does offer some cross protection, and that's not yet been verified in any way. Over.
Yeah, that's an important comparison point. A corollary to this question is what is, and I assume this would be a hypothesis, but what is hypothesized to be the impact of the level of community spread on the risk of, say, opening schools? So, is there a correlation between a higher level of community spread in a particular region and an increased risk of opening a school?
Yeah, this is a question that's plaguing most countries in the world today, is should we open our schools, should we not open schools? I think countries that have opened schools and ensured that there was physical distancing, and maybe even some that have required children to stay together whenever they move around in the school, a small group of children, so they can be self-isolated if that group does become infected. I think there are very many different ways of being approached to schools, and I don't think anybody can give that answer yet. There are concerns about teachers being infected and taking infection into the schools to children. There are concerns about children being infected and taking the infection to teachers. And these things have not yet been sorted out. And it will be a lot of trial and error. And that's why it's so important that there be monitoring systems in place so that when schools are opened and there's physical distancing in the schools and the assemblies and the cafeterias are not functioning because they don't want congregation of people, there needs to be some type of monitoring in that school to make sure that people aren't getting infected. If they are getting infected, then they need to close down those schools again. And so, to open up blindly would be wrong. Asian countries opened up with monitoring in place. They locked down, they opened up, they locked down. Germany is trying to do the same. All these countries have also continued their contact tracing activities to make sure that they're decreasing to the maximum the transmission from contacts into the communities. Not a good question, but it's a very difficult issue. And I know many countries are struggling with this just because there's a lack of information, Jen, really.
Yeah, that's really helpful, though, and the point that we need to have that monitoring system so that we can obtain data as these implementation strategies are put in place. Okay, Rebecca has a question. Some employers are asking for repeat testing of those employees that have tested positive. I assume that's to get a negative test before returning to work. When is the best time frame to be retested post-infection?
Well, most people say that 14 days after onset of signs and symptoms, you should be negative for PCR. But in South Korea, where there was a cohort of people followed up for periods after the 14 days, they found that 2 weeks later, some of those did have positive PCR testing. And they continued to watch those people. They continued to analyze what was going on. And they found that that was PCR fragments rather than positive PCR. So a general rule is that if a test is negative 14 days after onset of signs and symptoms, that person is no longer infectious. That's the rule that's being applied. And for discharge in hospitals, as you know, WHO recommends for people who are not very seriously ill and long-term patients, is that you go for a period of 10 days, and if on the 10th day that patient is asymptomatic, then after 3 more days being asymptomatic, that person could be discharged without a PCR. So there are very many different strategies, but a general rule is that 14 days after onset of signs and symptoms, provided a patient has become asymptomatic, they should no longer be carrying the virus. But there are exceptions.
Great. Okay, the next question is from Marta asking, is pool testing really a good tool to use?
Pooled testing conserves the PCR, and it certainly is good to use in where there's a population with a low number of positivities, because then the possibility that you'll find in your pool that you'll find a positive is lower. So when pooling is done, there are 2 things that are necessary to know: the incidence of the virus, and therefore the number of people that you should pool in order to have the best possibility of not having to retest all those people. So, if there's a low incidence, a pool of 10 might be useful, whereas a high incidence, you might go to a different strategy. Is that right? I think it's the reverse. So if you have a high incidence of disease, then you would want to decrease the number of people in that pool, and the opposite for a low incidence. Back to you, Jen.
Okay, that makes sense. Yeah. Okay, so the next question from Samar: when someone's been infected with COVID-19 and has now recovered, how long is that person protected from reinfection? And what's known about that, if anything?
That's the real question that people are asking, especially the vaccine developers. And as you know, there are 3 vaccines now that are in human phase 3 trials. So we should know a little bit more in the future. What we know now is based on our understanding of the epidemiology in animals that can be infected, in monkeys especially, but also we understand what happens in other coronaviruses. And as we all know, there are 4 endemic human coronaviruses, and those coronaviruses cause immunity, which is of non-durable. They cause immunity, but after 6 months or so, people can be reinfected with the same virus, but have a less serious illness. So we know that immunity is not solid enough to prevent infection, but immunity, we do believe, plays a role in the seriousness of infection in healthy people. What that might do in people with comorbidities and in people who are elderly is not known. We do know, though, that all these endemic coronaviruses do cause more serious illness in the elderly. And I might say a word on herd immunity, which people always ask as well.
Yeah, that'd be great.
And that may be useful to talk about now. People say, well, let's let the virus come in, there will be herd immunity, nobody else will get infected. Herd immunity depends on solid protection against infection, which we don't yet have from any vaccine, and we don't yet know whether the virus itself produces long-lasting or short-term prevention against future infection. And so we can't really say that herd immunity is important. Let's just wait for it to occur. We don't know whether it will occur. But if you look at diseases like measles, herd immunity is when there have been a majority, and a great majority, over 90% of people who have been infected and have developed a solid immunity. And even then, what happens is as children get older into cohorts in university, they can, if they're not vaccinated, become susceptible to outbreaks. So it's a lot of questions. This herd immunity concept is one that can't be considered at present. Neither can we consider what's very popular in Europe to talk about passports, immunity passports. If you're immune, you can safely go back to work. That we can't depend on either at this point in time. Back to you, Jen.
Yeah. Thanks, David. Yeah, there's just not enough known. Okay, I think we're going to try to fit in 2 more questions. So the first one here is Cyan, who's in India, has asked, what is your suggestion on strategies for reopening the crowded outpatient clinics in large Indian hospitals? What should be the screening strategies for patients in that setting? Any suggestions there?
It's a very, very tough issue, and I know it's tough in all countries, but what needs to be done is gradually, I think, that people have to be spaced within the waiting place, in the waiting rooms, And if everybody is wearing a mask in that waiting room, if anybody has COVID infection and could be transmitting, that will minimize the transmission in that waiting area. So physical distancing plus masks in an area where COVID is transmitting would be one way of protecting those people who aren't infected from becoming infected. It just depends on how the perception is in the various states in India or in states anywhere. I know, for example, in France that they allowed free movement of people into and out of places like stores and shops. And then on Monday of this week, they started requiring that again because they saw a slight increase in transmission that they linked to some places where people are going. So it's all about doing risk assessments and identifying which procedures will be implemented. And in the case of a waiting room, everybody wearing a mask will prevent others from getting infected if they're washing their hands at the same time and surfaces are washed down.
Okay,
Jen?
great. Thank you. Yeah. So for the very last question, I was just wondering if you could speak a little bit more. You mentioned in the presentation about the difference between, and I believe this was areas in China or countries in Asia where there was a total lockdown versus the difference where the places where there was extensive surveillance and intermittent lockdowns as needed.
Yes, the intermittent lockdowns in the countries where they were done, along with outbreak containment activities, trying to make sure that they did contact tracing and testing and identifying all cases, seem to have been able to keep the reproductive number less than 1, at least at the beginning. But today at the WHO Advisory Group, Hong Kong reported that they've now seen their reproductive number increasing. And it's increasing because there's been increased transmission locally, mainly, interestingly enough, they believe about people who were coming into Hong Kong who had been exempted from testing when they came in. These people were thought then, and there were very few of them, but they were airline crew, people on ships. It's thought that they then infected taxi drivers who then infected the general population. So, it's very important to look at what's happening. So they're locking down now certain sectors again in Hong Kong. So all I can say is that the ship is being built by many different strategies all at one time. Different countries have different strategies. Those that have continued with contact tracing and outbreak containment activities appear to have an easier time in keeping the reproductive number low after they've come out of lockdown situations, or those that didn't lock down entirely were able to keep it low during that period of time as well.
Thank you very much, Professor Heymann. And thanks to our listeners. As a reminder, to view the COVID-19 Comprehensive Resource Center on the Clinical Care Options website, click on the link in the show notes. Please be sure to check back regularly for more episodes on important infectious disease topics. Thanks!